Welcome to Ink and Air channel from optimalanesthesia.com, and the whole content will be available in optimalanesthesia.com from June 2025 with evidence-based explanation. Today, we're taking a fascinating deep dive into a case that really highlights how crucial a detailed understanding is in pediatric anesthesia.
Yeah, it really does.
We're looking at what seems, on the surface, like a pretty straightforward situation. A 6-year-old boy, new squint, needs an MRI under anesthesia,
Right.
but we're going to uncover the layers of complexity involved.
Exactly. And what's so compelling about this case, like you said, is how quickly a simple request for, sedation for an MRI can pivot into a much more intricate narrow anesthesia scenario. So our goal in this deep dive is really to understand the thinking, the decision-making process behind each step.
Yeah, and the potential challenges, too.
Yeah, identify those pitfalls and appreciate how recognizing even quite subtle clinical clues can lead to a really tailored, safe anesthetic approach.
Okay, so let's set the scene. We have this 6-year-old boy, and he shows up with a new squint.
Which is the key word there, new.
Right. Now, you might initially think, okay, eye muscles, something simple. But it was serious enough that it triggered a neurology referral. And that led to the decision for a brain MRI. And, well, anyone with kids knows, a 6-year-old isn't lying perfectly still for 45 minutes in a noisy tube.
Not a chance. So anesthesia is definitely needed.
Definitely.
And here's where things get really interesting from our perspective. That new squint, particularly if it involves the 6th cranial nerve.
Well, it's not always just about the eye itself.
Okay.
It can be a really significant neurological sign. I mean, sure, it could be something minor, but it's also a classic red flag for raised intracranial pressure, ICP.
Raised ICP, so increased pressure inside the head.
Exactly. Pressure inside the skull, something we absolutely have to factor into our plan.
So boom, right there, it's not just routine sedation anymore, is it?
Not at all. You immediately have to start thinking, okay, what could be causing raised ICP? Could it be a tumor? Could it be hydrocephalus that's fluid buildup? Or some other kind of lesion taking up space?
Precisely. Other space-occupying lesions. So suddenly the whole anesthetic approach needs to be much more, well, considered, more cautious.
Because if you just went ahead with a standard sedation plan without thinking about that potential high ICP,
you could run into trouble. Some of the drugs we commonly use, or even just how we manage the airway, could potentially make that pressure worse.
leading to negative outcomes, potentially serious ones.
Yeah, exactly. It raises the stakes considerably.
Okay, let's shift to the pre-op assessment then. A few things jumped out here. The child had fasted for 6 hours. That's standard.
Yep, standard procedure, MPO for 6 hours.
But, and this seems important, the pediatrician had recommended pre-op IV fluids, and the boy refused to drink them.
Ah, yes. That refusal. It might seem like a small thing, a kid being difficult, maybe.
Maybe just nervous or something.
But in pediatrics especially, a child refusing fluids, that's potentially quite significant. Kids, they have a higher percentage of body water than adults.
So they dehydrate faster.
Much faster. And even mild dehydration can really amplify the effects of the anesthetic drugs we give.
Okay, how so? Like with propofol?
Propofol is a great example. If you give a standard dose of propofol to a child who's even a little bit dehydrated, you might see a much sharper drop in blood pressure than you'd normally expect.
And that's bad news here, right?
Okay.
Because we're already worried about the brain.
Very bad news. We absolutely need to maintain good blood flow, good perfusion to the brain. If the ICP is already potentially high, dropping the blood pressure suddenly could compromise that cerebral perfusion.
Which is the last thing you want.
The absolute last thing. And there's another layer, too. Think about it. His age, 6 years old, he's been fasting, he hasn't had those extra fluids, plus the stress of the whole situation.
Yeah.
He's also at a higher risk for hypoglycemia, low blood sugar.
Even if he doesn't seem hypoglycemic.
Yeah, it might not be obvious clinically, but low blood sugar can sometimes manifest later, maybe as agitation when he's waking up, or just a delayed difficult recovery, something else to keep in the back of your mind.
Okay, so dehydration risk, potential hypotension with drugs, possible hypoglycemia. All from refusing those fluids.
It adds up. It definitely informs how you approach the anesthetic.
So given all these factors, the actual choice of anesthetic drugs becomes critical. This isn't just picking from a standard menu. It's about precision.
Absolutely. It's about a very targeted strategy. Let's walk through what they used.
Okay.
So right at the start, glycocurolate, 0.05 milligrams of 3-var.
Why glycopyrrolate?
Well, it helps manage secretions, dries things up a bit, but importantly, it can also prevent the heart rate slowing down too much, those vagal reflexes that sometimes fentanyl can trigger.
Sort of prepping the system.
Exactly, preparing the stage, you could say. Then, next, midazolam, just zero point 0.5 milligrams 3-var.
For anxiety.
Yeah, just a little bit of anxiolysis, take the edge off before the main induction, makes things smoother for everyone.
Okay. And then fentanyl.
Fentanyl, yes, a carefully chosen dose, 40 micrograms var.
Why fentanyl and why that specific dose?
Well, fentanyl provides some pain relief, minimizes discomfort from positioning in the scanner, but also helps blunt the body's stress response to the whole procedure.
Mm-hmm.
We chose 40 mics because it's enough to be effective, but not so much that we'd expect significant respiratory depression. We wanted him to keep breathing on his own. That was key to the plan.
Right. So for the actual induction, getting him off to sleep.
Propofol, but a very low dose, just 10 milligrams to 5.
10 milligrams. That sounds quite low for induction.
It is low, and that was a very deliberate choice, directly addressing our concerns about that potential dehydration and the risk of hypotension.
Ah, so trying to ease him into it gently without that big drop in blood pressure.
Precisely. A smooth, hemodynamically stable induction was the goal.
Okay, so he's induced. How do they keep him sedated for the full 45-minute scan, especially with things like contrast injection happening?
Good question. For maintenance, they used dexmedetomidine.
Dexmedetomidine.
Yeah. 10 micrograms mixed into a 50 milliliter bag of IV fluids and infused slowly over the course of the scan.
What's the advantage of using dexmedetomidine here?
Dexmedetomidine is fascinating. It provides sedation, but it's more of a sort of calm, cooperative state. Crucially, it tends to preserve respiratory drive. Patients usually keep breathing well on their own.
Which fits the plan.
Exactly. And importantly for this case, it generally has a more favorable profile regarding intracranial pressure compared to, say, volatile anesthetic gases. It doesn't tend to raise ICP.
So good for sedation, good for breathing, and potentially better for the brain pressure situation.
That's the thinking. It ticked a lot of boxes for this specific scenario.
You mentioned keeping him breathing on his own. Let's talk about airway management. What was the approach? Sounds like it was kept simple.
Very simple, and deliberately so. Just a standard face mask delivering oxygen.
No breathing tube, no LMA.
Nope. No endotracheal tube, no laryngeal mass airway. And crucially, no positive pressure ventilation. He maintained spontaneous ventilation throughout the entire procedure.
Why was this less is more approach the way to go here?
For a few key reasons. For relatively short MRI sedations like this, especially when you have these neurological concerns, maintaining spontaneous breathing is often the safest strategy.
Why is that?
Well, things like positive pressure ventilation, or even allowing the CO2 level in the blood to rise slightly hypercapnia, can increase pressure inside the chest.
Okay.
And increased chest pressure can make it harder for blood to drain back from the brain, which in turn can potentially increase that intracranial pressure we're trying so hard to manage.
Ah, I see. So letting him breathe naturally avoids those potential pressure increases.
Exactly. We wanted to avoid anything that might inadvertently push that ICP higher. Plus, there are the practicalities of the MRI suite itself.
Right. It's a tight space and access is limited.
Extremely limited. Once the patient is in the scanner bore, getting to the airway quickly if there's a problem is very difficult. So a simpler airway technique, like a face mask with spontaneous breathing, is often inherently safer in that environment. Less to go wrong, easier to manage.
Makes sense. You mentioned the dexmedetomidine infusion for maintenance, but were any other top-ups needed during the scan?
Yes, good point. To ensure he remained perfectly still, especially during potentially stimulating parts like the contrast injection, they gave small, intermittent boluses of propofol.
The same low-dose idea.
Yeah, just 5 milligrams each time. Given around the 20-minute and 40-minute marks, just enough to deepen the sedation briefly for those critical imaging sequences without significantly prolonging recovery.
Quick on, quick off.
Pretty much. Effective but transient.
Okay, let's talk monitoring. Obviously, in an MRI, you need special equipment.
Absolutely. Everything has to be MRI compatible. So standard monitors were used, ECG for heart rhythm, non-invasive blood pressure cuff cycled regularly, pulse oximetry for oxygen saturation.
And you mentioned capnography earlier. Tell us more about that.
Yes, capnography is crucial here. They used a nasal cannula that also sampled expired gas to measure end-tidal carbon dioxide, or ETHU.
Why is that so important when you don't have a breathing tube in?
Because it gives us a continuous, real-time, non-invasive window into his ventilation. How effectively is he breathing? Is he breathing adequately? Is he retaining Ku?
Even without a tube.
Yes. It's our best way to monitor the quality and stability of his spontaneous breathing. And the target, as we touched on, was normocapnia, keeping that ET coeuro value right around 35 to 40 millimeters of mercury.
And that target is specifically to protect the brain.
Exactly. Because even mild hypercapnia, a slightly elevated coeros, can cause the blood vessels in the brain to dilate. More blood flow sounds good, but in a situation with potentially raised ICP, increased cerebral blood flow can actually worsen the pressure. So keeping coeuro normal is critical.
It sounds like the team was really thinking ahead, anticipating potential issues constantly.
You have to in these cases.
What were some of the main complications they were prepared for, and how did the plan mitigate those risks?
Well, number one was probably hypotension from the propofol, especially with that dehydration concern.
Right.
That was mitigated by using that very low induction dose, the small top-ups, and just being hyper-aware and ready to treat it quickly with fluids or maybe pressors if needed.
Okay. What else?
Airway obstruction is always a possibility during sedation, especially without a secured airway. Maintaining spontaneous ventilation and avoiding overly deep sedation helps minimize this risk. And having airway equipment immediately available, of course.
Always plan B ready.
Always. Then there was the, albeit small, possibility of a seizure, given the underlying reason for the MRI, the neurological signs. So being prepared to manage a seizure was part of the plan.
And waking up? Any concerns there?
Emergence delirium. You know, kids sometimes wake up agitated or confused after anesthesia. It's always a consideration. But the specific drug combination used here, particularly the dexmedetomidine, actually tends to lead to a much smoother, calmer emergence. So that choice helped mitigate that risk too.
Towards the very end of the procedure, they gave a small dose of dextrose intravenously. 10 milliliters of 25% dextrose. Why was that done?
Yes, the dextrose. That was that proactive measure against potential hypoglycemia we talked about earlier.
Because of the fasting and stress.
Exactly. It might seem like a tiny amount, but giving that little bit of sugar helps ensure his blood glucose levels are adequate for a smooth wake-up. It addresses that risk factor and just helps ensure an uneventful recovery phase.
And it sounds like the recovery was smooth.
It was, thankfully. The report indicates the child woke up calmly, no nausea, no distress, fully awake and comfortable when transferred to the recovery unit.
That's a great outcome. Really validates the careful approach.
Absolutely. It really underscores the whole point of this deep dive.
So let's pull out some key takeaways from this case. What are the big lessons here?
Okay, first big one. A new squint in a child, like we saw here, shouldn't just be dismissed. It can be a sign of serious underlying neurological trouble, like raised ICP. Needs thorough investigation.
Definitely. Don't ignore the subtle signs. What else?
Second, paying really close attention to a child's hydration status is fundamental in pediatric anesthesia, and being aware of that hypoglycemia risk.
Yeah, the fluid refusal was a big clue.
It was. These factors can dramatically change how a child responds to anesthetic drugs and affects their whole recovery. Small details, big impact.
Okay, third point.
Third, specifically for these short MRI sedations, especially with potential brain issues, maintaining spontaneous ventilation, letting the child breathe on their own with minimal airway tinkering is often the safest bet.
To avoid messing with that intracranial pressure.
Precisely. Avoid anything that could increase ICP. Less is often more.
And
Finally, the drugs themselves. Careful selection and really precise dosing titrating agents like dexmedetomidine, fentanyl, and using that low-dose propofol strategy allows us to get the job done, effective sedation, without compromising the airway or, crucially, the brain's physiology.
It's a real balancing act, isn't it?
It really is a delicate balance informed by understanding the physiology and the potential risks.
This case, wow. It just perfectly illustrates the critical thinking, the detailed planning that goes into what might look like a routine pediatric MRI from the outside. And how these seemingly disconnected bits of information, a kid doesn't want to drink, he has a new squint, how they actually link together to guide the whole anesthetic plan. It's vital information.
It really is quite remarkable when you piece it all together. Those clues lead to a safer, successful outcome.
We really hope you found this deep dive insightful. And if you want to dig even deeper into the rationale, the specific dosage considerations, the evidence behind these choices, you can find the complete detailed write-up for this Squint Signals More episode packed with references over at optimalanesthesia.com. That'll be available starting June 2025.
Yeah, definitely check that out for the full picture. And, this case really gets you thinking, doesn't it, about those other subtle signs in medicine. What other, maybe seemingly small clinical findings might actually hold really significant implications in totally different situations?
That's a great question.
And how does really digging deep into understanding the physiology, the pharmacology, how does that empower us as clinicians to better anticipate things, to manage risks more effectively?
It's a powerful reminder, isn't it, that even when things seem straightforward on the surface, taking that deep dive, really looking at the details, that can make all the difference in the world.
Absolutely. It's where the real art and science of medicine happens.